Hello friends, welcome to a new lecture on diagnosis of pulmonary embolism. So before we go into the diagnostic aspects of pulmonary embolism, I would like to discuss a few diagnostic tests. First we will go into the diagnostic tests, and while doing with each diagnostic tests, I will show you all the X-rays, CT scans, and all the lungs tests, and what are the inference which we get through that. Okay, so the diagnosis can be divided into, all the diagnostic tests can be divided into one, that is non-imaging diagnosis, and number two, imaging diagnosis. Okay, in the non-imaging diagnosis, all the non-imaging diagnosis I would like to write with my pink color. Okay, so what non-imaging diagnosis which we have to see? The first one is D-dimer, which is most important. First we will do blood test. In the blood test we will measure the amount of D-dimer that is present. So what is D-dimer and why is it present in pulmonary embolism? As I have said, the thrombus is formed by an aggregate of platelets and the fibrin, right? In our body, whenever a thrombus is forming or is going to form, whenever thrombus has formed, then our body will have an enzyme which is called as plasminogen. This plasminogen will break down the plasmin, but it is an inactive form. So this plasminogen gets converted into plasmin, and this plasmin will result in the breakdown of fibrin monomers into many fragments, or fibrin polymers, okay, into fragments, and these fragments are called as D-dimer, and these D-dimer is measured by ELISA. By an ELISA we can measure these D-dimers. Obviously, because of thrombolysis which is happening in response to the thrombin formation, so D-dimer is produced and it is increased in pulmonary embolism. What are the other conditions in which D-dimer is increased? The most important, don't forget, the most important condition where D-dimer can be increased in is DVT, deep vein thrombosis. I forgot to tell one thing about the pulmonary embolism in my clinical features. I'm sorry. The issue is in pulmonary embolism, the patient may develop sudden breathlessness, right? But you should take the history of the patient. In the history, he might have calf pain or pain in the calf, because if you see, as I have said in my pathogenesis class, please refer to the pathogenesis class for better understanding of this topic now. As I have said, the pulmonary embolism mainly develops because of the emboli which are developed from the rupture of thrombi present in the deep veins. So in the deep veins there are thrombi which are present. These thrombi gets ruptured or dislodged, resulting in the formation of emboli. So the patient may have intermittent calf pains. That is, this is history of intermittent calf pains. Now he may have, he may not have, but intermittent calf pain may be there. That is history. So you should take this history into consideration. It is very important for diagnosis. Okay. Even in DVT there is increased D-dimer, and also in pulmonary embolism there is increased D-dimer. So D-dimer, it's not specific. Not specific because D-dimer is also increased in some of the conditions. It is increased in MI, pneumonia, that is infection of the lungs, or sepsis, or cancer, and in many other conditions D-dimer is increased. So once when D-dimer is present, we will try to establish that whether pulmonary embolism is present or not with a specific test. Okay, this is one non-imaging diagnostic modality. And the second non-imaging diagnostic modality is cardiac biomarkers. Why are cardiac biomarkers increased? Okay, let me tell you. In my pathogenesis class, I have said that there is right ventricular pressure increase. There is pulmonary venous pressure. Pulmonary arteries are blocked, so there is increased back pressure in the pulmonary arteries, increased back pressure in the pulmonary arterial trunk, and there is increased back pressure to the ventricles. And because of increased back pressure to the ventricles, this increase in tension causes hypertrophy of the ventricles and also dilatation of the ventricles. These dilated ventricles and hypertrophied ventricles will contract for a longer period when compared to the normal left ventricle. This results in bulging or compression of the left ventricle by the interventricular septum, which is in contraction of the right ventricle. So because of this contraction, I have said that this contraction of the right ventricle will also compress the cardiac veins, the arteries which are supplying the myocardium. As a result, there is decreased blood supply to the heart. Okay, so because this decreased blood supply to the heart, because of this, the heart suffers from ischemia, right? So because the heart suffers from ischemia, this causes myocardial. That is one thing, okay? And secondly, this occurs whenever there is myocardial infarction. And secondly, as I have said, the right ventricle undergoes stretching. Right? Here, there is right ventricular hypertrophy, right ventricular dilatation. Right ventricle is stretching. So, because of this stretching of right ventricle, there is microinfarction in the right ventricles that are happening in the wall of the myocardium. So, because of this microinfarctions in the right ventricle due to stretching and due to hypertrophy and atrophy leading to the microinfarction of right ventricle, there is release of troponin. Okay, this troponin increases. That is second biochemical, heart marker, cardiac marker. Okay, and because there is stretching of the myocardium, there is also stretching of myocardium, as I have said. Because of stretching of myocardium, the patient will also present with one more enzyme increased, which is brain natriuretic peptide, or NT-pro-brain natriuretic peptide. So both these will be increased in this situation. So this is the second diagnostic test which can be done. Okay, these two biochemical markers of cardiac biochemical markers are elevated. So this can also be done. Okay, these two are important. And then the third one is non-invasive test. The third invasive test, we are non-imaging test. We are doing non-imaging tests, right? The third non-imaging test is ECG. Okay, what do you see in ECG? I'll write here third ECG. So, what is the main abnormality? You will see right ventricular dilatation, hypertrophy, and then this will compress the left ventricle. That is the thing that is happening. If you see in normal ECG, I'll just draw normal ECG here. In normal ECG, P wave, QRS complex, and T wave. Okay, P wave, it will help in atrial depolarization. If this is the heart, atrial depolarization is by P wave. Okay, QRS complex, this will help in atrial ventricular depolarization. T wave helps in repolarization of ventricles. If you see, the atrial changes are seen late, right? In pulmonary embolism, mainly there is ventricular enlargement, right ventricular hypertrophy and enlargement, whereas right atrium changes are seen late in the course of the disease. So P wave will be normal. Okay, and then because the depolarization of the right ventricle is very difficult, the heart is trying hard to depolarize, right? It is pumping lots, it's not pumping, it's sending many electrical impulses to depolarize the bulky, hypertrophied, dilated right ventricle. So as a result, you see a sign in the right ventricle. That is, number one, there is S wave, deep S wave. So this is QRS. So you can see a deep S wave. Okay, this is first abnormality. Deep S wave can be seen. That is in lead 1. And second abnormality is you can see a deep Q wave also. Deep Q wave is seen in lead 3. And you can also see an inverted T wave in lead 3. So this is called as S1 Q3 T3 sign. So these two are in lead 3. So this wave pattern looks something like deep Q wave. Something like this. It looks something like this. Not exactly like this, but a little like this. Okay. So these are the different. This is in lead 3. Okay. These are the ECG changes which we see in pulmonary embolism. So all these are the non-imaging techniques. So what are the non-imaging techniques? There are 3. Number 1, D-dimers. Number 2, cardiac biomarkers. Number 3, ECG. Now, what are the non-invasive modalities? The second one, as I have said, non-invasive or imaging modalities. In the imaging, we will see non-invasive and invasive. Okay, so non-invasive, I will write with one more color so that you will not confuse it. Okay, these include number 1, venous ultrasound. So in venous ultrasound, you can see direct visualization of the thrombus. We can't read the ultrasound pictures, especially I can't read, I don't understand the ultrasound pictures. That is the reason why I did not put this. But generally, in the venous ultrasound, you can read the exact veins, and you can also see where the correct thrombus is present. Direct visualization of the thrombus is helpful through this venous ultrasonography. Why is this important in pulmonary embolism, right? This is because this is mainly to diagnose DVT. Because, as I have said, the major reason for pulmonary embolism is DVT, right? So, DVT, the veins from the lower leg can come and they can lodge here. So, here we do DVT to see the venous, to visualize the veins, to see whether the veins are compressible, and to see the thrombus directly. What are the criteria for establishing the diagnosis of acute DVT through venous ultrasound? Number 1, because here there is thrombus, some thrombus occluding the vein, at least completely or partially. Because of that, the compressibility of the vein will be lost. When you compress it, it will generally wink. But here, the winking of the vein is also lost. And then, if you compress it, if vein is like a tube, right? Like this tube, where if you just compress it, the two walls are touching with each other. If this is like this, if you are trying to compress it, you are able to compress it completely. But here, if there is thrombus, think that this syringe is a thrombus. So because of thrombus, you are not able to touch the posterior wall. So this touching of posterior wall is lost because of thrombus. Okay, so these 3 are the major criteria for DVT. What are they? Number 1, lack of compressibility. You are not able to compress it. Number 2, the veins does not wink. When generally compressed, see they are winking, but here there is no winking. And then you are not able to oppose the wall. Failure to oppose the wall like this. So these are the 3 major tests, criteria for establishing the diagnosis of deep vein thrombosis. So this is one imaging modality. And next, as these changes are happening in the chest. So the best modality, the one of the, not best, it gives an idea that it is pulmonary embolism, but mostly it's normal. That is chest X-ray, chest röntgenography. Never say X-ray, it's chest röntgenogram or chest radiogram. Röntgenography or chest radiography. So if you do a chest radiograph, then it will be normal, completely normal or near normal. But there are some abnormalities which you see. Just take this one. I think you are able to see it, right? Yeah, if this is the one, so this is the chest radiograph. If it's not pointed, it looks more or less normal, right? There are 3 major well-established abnormalities which are seen. I will just mention them clearly right now. This, if you see this one, here there is no airway. If you see, just see it so closely. If you just see it closely, here you will have some some blood vessels flowing through it. This is one, this is one, this is one. But here there is some translucency. There is no blood vessels flowing from it. That is, there is translucency here. So this translucency is called as focal oligemia. Why? This is because here if you see, there is some dilated blood vessel. Here there is no. You can just compare. If you don't know, if you don't understand whether it is normal or abnormal, always compare both the sides in chest X-ray. So here there is some bulging. You can even see here. See here there is some dilated vessel. Here there is no. So this dilatation of, this is right side, right? So right descending pulmonary artery is dilated. So this dilatation of right pulmonary descending artery is called as Pallas sign. What is it? Dilatation of right pulmonary descending artery. So because there is dilatation of this artery here, okay, there is some block here, right? Because there is some obstruction here, there is dilatation here. Because of this obstruction, the distal part which is present, okay, this distal part is collapsed. See, there is no blood vessels. If you see here, there are blood vessels. This is 1 blood vessel, 2, 3, even here 1, here 1, which are radiolucent. Some blood vessels are there, but here there are no blood vessels. So because of that, this is a collapsed region. So this is called as a sign which is called as Westermarck sign. Okay, even here you can see this is the place where collapse is there. So that is Westermarck sign. Okay, these are the 2 changes. And the third change is here. Here, this is the diaphragm. This is the diaphragm. But here if you see, there is a wedge-shaped density over the diaphragm. There is nothing here. Here it's clear. So this wedge-shaped density over the diaphragm is called as Hampton's hump. Hampton's hump. This is a wedge-shaped density above the diaphragm. Okay, above the diaphragm. So these are the 3 changes which are seen in chest X-ray. Now, what do you see in CT? Then you'll order for CT. Once you order for CT, you will see in CT you can even see or visualize the 6th order branches of pulmonary artery. So as a result, here there is emboli here. There is emboli here. Like this. Even you can see even the smallest of the smallest vessels. So these are the embolism plaques which are seen. Okay. So these are the different things. If you wanted to see the normal one. So this is not a normal one. It differs. The levels differ. But if you see, this is the pulmonary trunks, which are clear. There is no opacity here. There is no greyish shadow here. Yet it's clear. But here there is some greyish shadow here. So this is nothing but an emboli. Okay. So this embolism can be detected. The thrombus can be detected through this. And then you'll have to do a lung scanning is also present. Just a minute. Yeah. Lung scanning is nothing but ventilation perfusion ratios are measured through it. So if you see, ventilation is this greyish color. This is the perfusion through blood vessels. If you see, these are at different levels of the lung. Okay. So this is the ventilation. This is the ventilation. The light gray one is the ventilation, and this darkish one is the perfusion. So here there is ventilated. ventilation or perfusion are normally equal. But if you see here, the ventilation is present but perfusion is lost. Okay, then this, if you see here the ventilation is present but perfusion is lost. Even here ventilation is present but perfusion is lost. Even here, see, the whole part of this, here there is no ventilation, there is only there is no perfusion, there is only ventilation. So if you wanted to see again the newer one, here the darker one, this is ventilation, this is perfusion, sorry, darker is bled, so perfusion. Remember, darker is bled, so perfusion, lighter is air, so ventilation. Okay, so if you see, it is not completely perfused. Here there is lack of perfusion. Even here there is some lack of perfusion. Here, see, this lobule, there is lack of perfusion. Here this part, there is lack of perfusion again. This part, lack of perfusion. So why is there lack of perfusion? Because there should be obstruction prior. Only when there is obstruction prior, there is lack of perfusion in the distal part. So this ventilation perfusion scan or the so-called lung scan will help us to know whether there is pulmonary embolism or not. Okay, and then you can also do one more test, which is echocardiography. I really don't know much about reading echocardiography, but this one I brought it from internet, so I'm not sure. All these are from internet, but I don't know about reading an echocardiography. But I can say this is the right ventricle, this is the left ventricle, right? Generally here the size of the right ventricle is increased. This we can see. This is the right ventricle, this is the left ventricle. The size of the right ventricle is increased. As I have said, there is right ventricular hypertrophy in pulmonary embolism. I'll show you the picture which I have drawn. I'm sorry, just a minute. I'm really sorry for this. Yeah. So here if you see, there is right ventricular hypertrophy. So here there is right ventricular enlargement, right? That one thing we can say. And then there is some sign which is called as McConnell sign, which is useful for which indicates the pulmonary embolism. But truly speaking, pulmonary embolism, this echocardiography is not reliable. It is not a diagnostic tool for pulmonary embolism. It is only to exclude the other causes, because if a person comes to you with chest pain and dyspnea, sudden dyspnea, and if you are not now, if you have a doubt that he might have even other abnormalities like mitral valve defects or valvular abnormalities or any other abnormalities, in such cases, in order to exclude them, we do echocardiography. Apart from that, there is no use for echocardiography, role for echocardiography in pulmonary embolism. But there is a sign in transthoracic echocardiography which you see, that is an indirect sign for pulmonary embolism, that is hypokinesis of the right free wall and normal motion of right ventricular apex. Right ventricular apex, the motion will be normal, but the free wall of the right ventricle, the motion will be less. How is it? I'm not sure, I don't know. If you guys know, please comment it in the comment section. So finally, the last and finally is invasive tests. In the invasive tests, you know, it's a blood vessel, so you'll have to do an angiography. So we do pulmonary angiography. How is pulmonary angiography done? This pulmonary angiography, just okay, leave about the those things, but the technical aspect of it. But pulmonary angiography is an invasive modality. But right now we don't do any pulmonary angiography because CT scan, it's diagnostic. If you see the CT scan, you can see the emboli directly. So we don't need to puncture the vessel, do an invasive test like pulmonary angiography if a better investigation like CT scan is available. So in pulmonary embolism, see, if this is the trunk and these are the small branches, you can see an emboli here. Okay, similarly I have even one more scan. Yeah, here, see, this is so dark, you can clearly find it, but here there is a block. Okay, so these are the pulmonary angiographic findings which are there. But I have said you all the invasive tests, all the non-invasive tests, but how are you going to do? Are you going to order all these to a person who comes to you with a clinic? See, a person, he will have less resources. In such a case, how are you going to treat him? Or how are you going to diagnose it? It's simple. If it's pulmonary embolism, if you suspect that the person may have pulmonary embolism, just suspicion, first get off and go and do chest CT. Because pulmonary embolism is an emergency situation, the person, if the embolism is present in the main pulmonary trunk or in the pulmonary arteries, it's really emergency. You should act faster. So for that reason, you'll have to do a chest CT. If this chest CT, if you see positive, as I have said, then stop it and treat it for pulmonary embolism. If this chest CT you cannot see some emboli or it's not diagnostic, then you will go and do a lung scan. The ventilation perfusion scan, which I have said, that is the lung scan. If this is positive, then if there is ventilation but absent perfusion in some regions of the lung, then you stop doing it. Then treat it. If it's not diagnostic, then do venous ultrasound. Why? Because there may be DVT. So to diagnose DVT, we do venous ultrasound. If this is diagnostic, then that's fine. If it's negative, then go to the other techniques like echo, MRI, or any other techniques. So these are the different ways how you diagnose a pulmonary embolism. I think I have correlated it well to the pathophysiology and clinical features. So if you want to refine the lecture in any way, please comment it in the comment section. Thank you guys for watching my lecture. If you feel this is a little faster, even then comment it in the comment section. Thank you for watching my lecture. Thank you.